Okay, we're on chapter 32, medication administration. In all settings, nurses are responsible for evaluating the effects of medications on patient ongoing health status. It's constantly evolving. Teaching them about their medications and side effects is part of our responsibility as nurses. And then also ensuring adherence to the medication regimen. And then evaluating the patients and the families or the family caregiver's ability to self-administer medications. We have to really be precise on this education too of our patient and their family. And when we talk about delegation, I keep referencing that so that you'll start training your mind to think about delegation, because when you do take leadership and some other classes, this is going to be extremely important. NCLEX likes to ask about delegation. So I just want to interject here that the LPNs can administer most medications, and remember our RNs can assess, teach, and evaluate. Okay, so the pharmacist prepares and distributes prescribed medications. They're responsible for filling prescriptions accurately and being sure that prescriptions are valid. Pharmacists and healthcare agencies rarely mix compounds or solutions, so except in the case of IV solutions, they do those. Most medication companies deliver medications in a form ready for use. Dispensing the correct medication in the proper dosage and amount with an accurate label is the pharmacist's main task. Pharmacists also provide information about medication side effects, toxicity, interactions, and incompatibilities. And then the nurse's role in administering medications is as crucial as those of physicians and pharmacists. Administering medications requires unique nursing knowledge and skills. So you first determine that the medication ordered is the correct medication. As a nurse, you need to assess the patient's ability to self-administer medications. You need to determine whether a patient should receive a medication at a given time, and then you have to administer medications correctly. And also, you will be closely monitoring that medication's effects. Do you delegate any part of the medication administration process to nursing assistive personnel? No. Patient and family education about proper medication administration and monitoring is an integral part of your role. Begin instruction, you're going to have to start teaching them about medications that the patient will be taking home as soon as possible, because sometimes it's difficult to instill this into our patients and their families. Okay, so critical thinking, I think probably you've been introduced to this in pharmacology already, but we're also going to go over this in lab, and then your textbook is a great resource as well. So you have the 6 rights: right medication, right dose, right patient, right route, right time, right documentation. So to prevent medication errors, follow the 6 rights of medication administration consistently every time you administer medications. Many medication errors can be linked in some way to an inconsistency in adhering to these 6 rights. Regardless of how the nurse receives a medication order, he or she compares the prescriber's written orders with the medication administration record, or you may hear it called MAR, M-A-R, or the electronic medication administration record, EMAR, when medication is initially ordered. So when performing medication calculations or conversions, have another qualified nurse check the calculated doses. An important step in safe medication administration is making sure that you give the right medication to the right patient before administering the medication. Use at least 2 patient identifiers, okay? Always consult the prescriber if an order does not designate a route of administration. Likewise, if the specified route is not the recommended route, alert the prescriber immediately. You need to know why a medication is ordered for certain times of the day and whether you are able to alter the time schedule. A medication order is required for every medication that you administer to a patient. If any question arises about the medication order because it is incomplete, illegible, vague, or not understood, contact the prescribing healthcare provider before administering the med. Never document, by the way, never document that you have given a medication until you have actually given it. This can turn around and kind of bite you because if you go ahead and say that it was administered, several things could happen, one of which the patient may refuse it, or maybe they are nauseous and they throw it out, whatever. I'm just trying to say that make sure you wait until after you give medication. Also, if you go to your patient and they say, I've never heard of this medication or I don't take that medication, that is a red flag to go and double check that the order is correct, okay, and that you read it correctly. In accordance with the Patient Care Partnership, American Hospital Association came up with this goal in 2003. So in accordance with the Patient Care Partnership, and because of the potential side effects related to medication administration, a patient has the following rights. Make sure you know these patient rights. They have the right to be informed of the name, purpose, action, and potential undesired effects of a medication. They have the right to refuse a medication regardless of the consequences. What do you do if a patient refuses a medication? Good question. You want to ask the patient, what's the reason for refusal? And then you're going to educate them. You document that they refused and that you did educate them, and then you want to notify the physician. Okay? They also have the right to have qualified nurses or physicians assess a medication history, including allergies and use of herbals. Don't forget to ask your patient about that. Sometimes they forget the herbals of the supplements. To be properly advised of the experimental nature of medication therapy and to give written consent for its use. This is also a patient's right. They also have the right to receive labeled medication safely without discomfort in accordance with the 6 rights of medication administration. They have the right to receive appropriate supportive therapy in relation to medication therapy. They have the right to not receive unnecessary medications, and they have the right to be informed if medications are part of a research study. Before you administer medications, review a patient's medical history to help you understand the indications or contraindications for medication therapy. Some illnesses place patients at risk for adverse medication effects. Ask your patient questions to find out about medication they take. In addition, review the action, the purpose, normal dosage, route, side effects, and nursing implications for administering and monitoring each medication. You always want to ask them about their diet history as well. Teach your patient to avoid certain foods that may interact with medications, and this would be per that medication. Patients with perceptual or fine motor or coordinated limitations often have a lot of difficulty with self-administration medications. So keep this in mind. If a patient is unable to self-administer medications, assess if families or family members or friends are available to help take that medication. Okay? Or if they don't, make sure you make a home care referral. The ongoing physical or mental status of a patient affects whether a medication is given and how it is administered. Assess a patient carefully before giving any medication. Be aware that cultural beliefs about Western medicine sometimes interfere with medication adherence. And adherence to medication therapy, make sure you ask, are you taking the medications as ordered? Why might they not be? You want to ask this as well, because maybe I hate when people say they're non-compliant, because we don't really know why they might not be taking their meds. That's why we have to ask them, are there financial issues that we can help them with? Maybe they have a knowledge deficit, the purpose of the med, or, things about the medication. So you want to make sure that you investigate. They may not be taking them too because of side effects. Some of these medications have really, really tough side effects for our patients to go through. So we need to ask about all of this. Okay, so we're at this slide that says nursing diagnosis, and I just want to alert you guys. I try to make sure that I tell you every time we come across nursing diagnosis as per whatever we're studying, because these are great resources for you to kind of, put aside so that you'll be able to come up with the correct nursing diagnosis for the subject that we're talking about. So anyway, when we're talking about MedAdmin, these are certain medication nursing diagnoses that you could come up with. Use assessment data, okay, to determine a patient's actual or potential problems with medication therapy. This list of nursing diagnoses shown may apply during MedAdmin or, in a variety of settings. So after selecting the diagnosis, identify the related factor, if applicable, that drives the selection of nursing diagnosis. Okay, in the planning phase, it's important to minimize distractions or interruptions when preparing and administering meds. There are actually at facilities, I don't know if you guys knew this or not, but they have what's called no interruption zones. So those are around any kind of medication cabinet or anything that involves MedAdmin. So there are no interruption zones that have been recommended to reduce distractions and interruptions during medication administration. We don't want to be distracted, right? So prioritize care when administering medications. Use patient assessment data to determine which medications to give first, whether it is time to evaluate a patient's response to a medication, or if it is appropriate to administer PRN medications or as needed. Collaboration during medication administration is essential. Family caregivers and significant others often reinforce the importance of medication schedules when a patient is at home. But nurses often collaborate with patients' healthcare providers, pharmacists, maybe referral for patients with polypharmacy use, which means that they have multiple medications that are going on, and some providers may not know that another provider is prescribing maybe the same medication. And also, we could involve case management to ensure that patients are able to afford their medication. That's where we can get help for that. That's very tragic to me that does happen. Okay. Several nursing interventions promote adherence to the medication regimen and foster independence. So teach a patient and family about the benefit of a medication and the knowledge needed to take it correctly. Integrate a patient's health beliefs and cultural practices into the treatment plan. Help a patient and family establish a medication routine that fits into the patient's normal schedule. Make referrals to community resources if a patient is unable to afford or cannot arrange transportation to obtain necessary medications. Some patients take medications incorrectly or not at all because they don't understand their medications. When this happens, you need to provide patient education using language your patient understands. Include information about the purpose, the actions, the timing, the dosages, and side effects of medications. Patients also need to know the symptoms of medication side effects or even toxicity. All patients need to learn the basic guidelines for medication safety, which ensures the proper use and storage of medication in the home. I want to reference a page here. You know how I like to talk about the boxes. Please go to page 631 and review that box 32-9. It talks about patient teaching safe insulin administration. Okay. So all children require special psychological preparation before receiving medication. So if you're working in peds, let's not forget about that. A child's parents are often valuable resources for determining the best way to give medication to the child. So we're going to involve the parents as well in that setting. Older adults, okay, keep instructions very clear and simple for them. Provide memory aids, maybe a weekly pill box. They may need written information in large print about the medication. Difficulty swallowing pills. So is a liquid form available, you want to ask? Do they need to take it with a small amount of food if it's not contraindicated? Things like that. Also, don't forget about polypharmacy. This happens a lot. Not so much, hopefully not so much anymore, because the pharmacies are able to communicate with the healthcare facilities and kind of do that. Go through the medications, make sure that they are correct. Okay. Also, some people may have incorrect beliefs about medications and visiting several healthcare providers. So we hope that we're communicating between providers, but just make sure you're the person that could review that with the patient to catch it sometimes. What's the last step of medication administration? That is documentation. So follow your agency policies when documenting medication administration. If a patient refuses a medication or is undergoing tests or procedures that result in a missed dose, explain the reason that a medication was not given in the nurse's notes. And be aware of the effects that missing doses have on a patient, like with hypertension and diabetes, different things like that. So coordinating care with healthcare providers and other services when testing or diagnostic procedures are being completed helps ensure patient safety and therapeutic control of the disease. The goal of safe and effective medication administration is met when a patient responds appropriately to medication therapy and assumes responsibility for self-care. When patients do not experience expected outcomes of medication therapy, investigate possible reasons and determine appropriate revisions to the plan of care. Carefully monitor a patient's response to a medication, especially when the first dose of new medication is administered. A sound knowledge base is required for medications to be administered safely. Nurses need to be prepared to administer medications using a variety of routes. These are listed on this slide: oral, topical, inhalation, irrigation, parenteral, and injection. So we'll go over that a little bit more. Patients usually are able to self-administer oral medications, typically. Give oral medications on an empty stomach if absorption is decreased, or give oral medications with meals if absorption is enhanced by food. So you really have to know which is the best. Most tablets and capsules need to be swallowed and administered with approximately 60 to 240 mL of fluid as allowed. Make sure that you're looking at their dietary restrictions. Protect a patient from aspiration by assessing his or her ability to swallow. Please look at page 635, box 32-13, protecting a patient from aspiration. Sublingual administration. Some medications like nitroglycerin, for example, are readily absorbed after being placed under the tongue to dissolve. Instruct patients not to swallow a medication given by the sublingual route or drink anything until the medication is completely dissolved to ensure that the medication will have the desired effect. And you really have to watch out for this because I've given medications before that were sublingual, and I don't know, they just kind of, you have to reinforce that because they forget, and then they're chewing the medication, so it's not going to have its desired effect. Buccal administration, remember, that's in the cheek. Administration of a medication by the buccal route involves placing the solid medication in the mouth against that mucous membrane of the cheek until it dissolves. Very important. So teach your patients to alternate their cheeks with each subsequent dose to avoid mucosal irritation. And warn patients not to chew or swallow the medication or take it with any liquids if it's buccal. A buccal medication acts locally on the mucosa or systematically, as it is swallowed in a person's saliva. So this is important that they take it this way. Medications applied to the skin and mucous membranes generally have local effects. Systemic effects often occur if a patient's skin is thin or broken down, the medication concentration is high, or contact with the skin is prolonged. A transdermal disc or patch has systemic effects. The disc secures the medicated ointment to the skin. These topical applications are left in place for as little as 12 hours or for as long as 7 days. So we're talking about patches like the fentanyl patch or the nicotine patch. You apply topical medications to mucous membranes through direct application or a liquid or ointment. Or it could be by insertion of a medication into a body cavity or installation of fluid into a body cavity where fluid is retained. Irrigation of a body cavity is also a way to administer these. I want you guys to look on page 639 and review that box 32-16, which is entitled Procedural Guidelines, Administering Nasal Medications. Okay? The most commonly administered form of nasal instillation is decongestant spray or drops, used to relieve symptoms of sinus congestion and colds. Caution patients to avoid abuse of these kind of medications because overuse can lead to a rebound effect. So what happens in a rebound effect is that maybe they're using the nasal spray to relieve nasal congestion, but it can actually, if they get habitual with it or abusive with it, it can actually cause nasal congestion. It can make it worse. Okay. When excess decongestant solution is swallowed, serious systemic effects also develop, especially in children. It is easier to have patients self-administer sprays because they're able to control the spray and inhale as the medication enters the nasal passages. For patients who use the nasal sprays repeatedly, check the ears for irritation. When used to treat a sinus infection, position patients to permit the nasal medication to reach that affected sinus, and that's what it shows you in the picture. Severe nosebleeds are usually treated with packing nasal tampons. It'll talk about that in your book. It really is kind of like a tampon that goes into the nair to stop nosebleeds sometimes when they're extreme. And the actual tampon is treated with epinephrine to reduce the blood flow. So usually a physician or advanced practice clinician places these nasal tampons. Okay. Nurses administer inhaled medications through the nasal and oral passages, or endotracheally or tracheostomically into their tracheostomy tubes. Inhaled medications are readily absorbed and work rapidly because of the rich vascular alveolar capillary network present in the pulmonary tissues. Many inhaled medications have local or systemic effects. Medications commonly used by patients include eye drops and ointments, including over-the-counter preparations such as artificial tears and also vasoconstrictors. Many patients, especially older patients, receive prescribed ophthalmic medications for eye conditions such as glaucoma or after cataracts have been removed. So, age-related problems include poor vision, hand tremors, and difficulty grasping or manipulating containers. They affect the older adult's ability to self-administer eye medication, so you want to watch out for this. Instruct patients and family members about proper techniques for administering them. Determine the patient's and the family's ability to self-administer through, like, maybe you want to do a teach back or return demonstration of the procedure. Showing patients each step of the procedure for instilling eye drops can improve adherence. Also, review skill 32-2. It's called Administering Ophthalmic Medications. The cornea of the eye has many pain fibers, and so it's very sensitive to anything applied to it. Medications delivered intraocularly resemble like a contact lens. They show you this in your book as well. Some medications come like it looks like a contact lens. So you want to place the medication into the conjunctival sac on these where it remains in place for it could remain in place up to a week. Patients require teaching about monitoring for adverse reactions to these discs. They also need to know how to insert and remove the discs themselves. Because internal ear structures are very sensitive to temperature extremes, you need to install eardrops at room temperature to prevent vertigo, dizziness, and nausea. And when you have to irrigate a patient's ears, make sure you do have the liquid at room temperature. They easily, if you do it prolonged amount of time, they can become very dizzy. Okay. Although the structures of the outer ear are not sterile, sterile solutions are used in case the eardrum is ruptured. The entrance of non-sterile solutions into the middle ear structure often results in infection. If a patient has ear drainage, be sure that the eardrum has not ruptured. Never occlude or block the ear canal with the dropper or irrigating syringe. Forcing medication into an occluded ear canal creates pressure that injures the eardrum. And go by and take a look at box 32-17, which is called Procedural Guidelines Administering Ear Medications. Okay, so vaginal medications are available as suppositories, foam, jellies, or creams. And because vaginal medications are often given to treat infection, discharge is usually foul-smelling. Follow aseptic technique and also offer the patient frequent opportunities to maintain perineal hygiene. Solid oval suppositories come individually packaged in foil wrappers and sometimes are stored in the refrigerator to prevent them from melting. After a suppository is inserted into the vaginal cavity, both temperature causes it to melt, body temperature causes it to melt and be distributed and absorbed. Apply sterile water-based lubricating jelly to smooth or round tip end of the suppository. Patients often prefer administering their own vaginal medications and need privacy. If they're able to do this, you want to ensure that. Foam, jellies, and creams are all administered with an application inserter. Rectal suppositories are thinner and more bullet-shaped than vaginal suppositories. The rounded end prevents anal trauma during insertion. Rectal suppositories contain medications that exert local effects such as promoting defecation or systemic effects such as reducing nausea. Rectal suppositories are often stored in the refrigerator until administered. Sometimes it's necessary to clear the rectum with a small cleaning enema before inserting a suppository. So when you do insert these, you'll see in the diagram The incorrect placement would be into the stool. So you want to make sure that you get up against that wall of the rectum where it's going to be absorbed, like in the right side of the picture, okay? So when we give these, we want to help the patient to the Sims position, lubricate rounded end of suppository with sterile water soluble lubricating jelly. Insert suppository past internal sphincter and against rectal wall, 4 inches in adults, 2 inches in the children and infants. Have patient remain flat or on their side for at least 5 minutes to prevent expulsion of the suppository. So what happens sometimes is that sometimes even if they do have good sphincter control, but mostly when they don't have good control, you could put the suppository in and they get up and then it comes right back out. So it's defeated its purpose. Medications administered with handheld inhalers are dispersed through an aerosol spray, mist, or powder that penetrates lung airways. The alveolar capillary network absorbs medications rapidly. Please reference pages 664 to 665 for pictures. Pressurized metered dose inhalers, breath-activated metered dose inhalers, and dry powder inhalers deliver medications that produce local effects such as bronchodilation. MDIs, or the metered dose inhalers, use a chemical propellant to push the medication out of the inhaler and require the patient to apply approximately 5 to 10 pounds of pressure at the top of the canister to administer the medications. Children or older adults with chronic respiratory diseases often use the MDIs, or metered dose inhalers. BAIs, or breath-actuated metered dose inhalers, they release medication when a patient raises a lever and inhales. Release of the medication depends on the strength of the patient's breath on inspiration. And a BAI is a good choice for patients who have difficulty using MDIs because it eliminates the need for hand-breath coordination. DPIs, dry powder inhalers, hold dry powder medication and create an aerosol when the patient inhales through a reservoir that contains a dose of the medication. Some DPIs are unit dosed. Dose inhalers require patients to load a single dose of medication into the inhaler with each use. Other DPIs hold enough medication for a month. DPIs require less manual dexterity because the device is activated when the patient's breathe. There's no need to coordinate that dispensing. So what they're saying is that, with the metered dose inhaler, it takes some coordination and some strength in their hands to be able to press that as they take a breath in. But some of these other administrations, like with the breath actuated metered dose inhaler, they just have to breathe in, right? Whenever they do, it doesn't have to be at the same time. It can be sequentially. Also, the dry powder inhalers, that's only activated by that patient's breath, so they don't have to have all that coordination. Now, sometimes some patients use a spacer with the MDIs. The spacer is like a 10 to 20 centimeter or 4 to 8 inch long tube that attaches to the MDI and allows the particles of medication to slow down and kind of break into smaller pieces, which improves the drug absorption in a patient's airways. BAIs and DPIs do not require the use of spacers, so remember that. To ensure that the patient does not run out of medications, by the way, teach him or her to refill it at least 7 to 10 days before it runs out. Parental administration of medication is the administration of medication by injection into body tissue. This is, like you would think, an invasive procedure that is performed using aseptic techniques. A risk of infection occurs after a needle pierces the skin. The effects of a parenteral medication develop rapidly, by the way, depending on the rate of medication absorption. You must closely observe a patient their response to parental medications. Each type of syringe, by the way, is designed to deliver a certain volume of a medication to a specific type of tissue, using nursing judgment when determining the syringe size or needle length and gauge that will be most effective. In general, syringes are classified as either being luer lock or non-luer lock. So the luer lock syringe have needles that are twisted onto the tip and lock themselves in place. This design prevents the inadherent removal of the needle. Syringes come in a number of sizes, from 0.5 to 60 ml. The tuberculin syringe has a capacity of a total of 1 ml. Insulin syringes are available in sizes that hold 0.3 to 1 ml and are calibrated in units. And by the way, the non-luer lock syringes have needles and slip into the tip. Syringes have safety devices to prevent needle stick injury as well. Only touch the outside of the syringe barrel and the handle of the plunger to maintain sterility. Avoid letting any unsterile object touch the tip or inside the barrel, the hub, the shaft of the plunger, or the needle. Some needles come packaged in individual sheaths to allow flexibility in choosing the right needle for a patient, whereas others are pre-attached to a standard size syringe. A needle that has 3 parts, the hub, which fits into the tip of the syringe, the shaft, which connects to the hub, and the bubble or slanted tip. Most needles vary in length from about 1/4 to 3 inches, 1/4 of an inch to 3 inches. Choose the needle length according to a patient's size and weight and the type of insulin the type of tissue into which the medication is to be injected. Use longer needles from like 1 to 1.5 inches for IM injections and shorter needles like 3/8 inch to 5/8 inch for subcutaneous injections. As the needle gauge becomes smaller, the diameter becomes larger. The selection of a gauge depends on the viscosity or the thickness of the fluid to be injected. Disposable single-dose prefilled syringes are available for some medications. Be careful to check the medication and concentration because prefilled syringes appear very similar to each other. With these syringes, you do not have to prepare medication doses except perhaps to expel parts of unneeded medications. The Tubex or Carpuject injection systems include reusable plastic mechanisms that hold pre-filled disposable sterile cartridge needle units. To assemble a pre-filled system, place the cartridge barrel first into the plastic syringe holder. Following manufacturer directions, turn the plunger rod to the left, which is counterclockwise, and lock to the right until it clicks. Finally, remove the needle guard and advance the plunger to expel air and excess medication as in a regular syringe. The glass cartridge can be used with needleless systems or safety needles. After giving the medication, safely dispose of the glass cartridge in a puncture-proof, leak-proof receptacle. So that would be like a Sharps container. So these are, I don't know how often you'll use a Carpuject. We used to use them quite frequently. It just depends on how does that manufacturer manufacture that medication and how does your hospital order it. But anyway, that thing that she's holding in her hand, that's what I was describing the steps on how to administer that. And if you're like me, I really kind of have to put hands on. And I don't have one of those to show you guys, just from the picture I have it. But essentially what happens is you just put the medication that she's holding, comes in like a glass long sheath, and you put that into your Carpuject and you just kind of twist it down, and then you're ready to give the medication with the plunger. Ampules contain single doses of medication in a liquid. They're available in several sizes from 1 ml to 10 ml or more. An ampule is made of glass with a constricted neck that must be snapped off to allow access to the medication. A colored ring around the neck indicates where the ampule is pre-scored so you can break it easily. Carefully aspirate the medication into a syringe with, very important, with a filter needle. The use of a filter needle prevents particulate matter such as small glass fragments from entering the syringe. Replace the filter needle with an appropriate size needle or a needleless access device before administering the injection. You can go to skill 32-4. It's called Preparing Injections from Vials and Ampules to review this. A vial is a single dose or multi-dose container with a rubber seal at the top. A metal cap protects the seal until it's ready for use. Vials contain liquid or they may contain dry forms of medication. Medications that are unstable in solution are packaged dry. The vial label specifies the solvent or the diluent used to dissolve the medication and the amount of diluent needed. Unlike the ampule, the vial is a closed system and air needs to be injected, by the way, into it to permit easy withdrawal of the solution. So this is like a physics thing that is kind of difficult to explain, but you definitely have to insert air into these vials, not the ampules, but into the vials to be able to withdraw that medication. What you're going to do is insert the amount of air that's equal to the amount of medication volume that you're withdrawing. Failure to inject air when withdrawing creates a vacuum within the vial that makes withdrawal very difficult. If you're concerned about drawing up parts of the rubber stopper or other particles in the syringe, use a filter needle when preparing medications from vials. After mixing multi-dose vials, make a label that includes the date and the time of mixing and the concentration of medication per milliliter. Some multi-dose vials require refrigeration after the contents are reconstituted. If two medications are compatible, it is possible to mix them in one injection if the total dose is within accepted limits. This prevents a patient from having to receive more than one injection at a time. Most nursing units have charts that list common compatible medications. If there is any uncertainty about medication compatibilities, consult a pharmacist or a medication reference book. When mixing medications from both a vial and ampule, prepare medication from the vial first. Using the same syringe and filter needle, next withdraw the medication from the ampule. Nurses prepare the combination in this order because it is not necessary to add air to withdraw medication from an ampule. Apply these principles when mixing medications from two vials. Number 1, do not contaminate one medication with another. Ensure that final dose is accurate. And number 3, maintain aseptic technique. Use only one syringe with a needle or needleless access device attached to mix medications from two vials. Aspirate the volume of air equivalent to the dose of the first medication, vial A. Inject the air into vial A, making sure that the needle does not touch the solution. Withdraw the needle and aspirate air equivalent to the dose of the second medication, vial B. Inject the volume of air into vial B. Immediately withdraw the medication from vial B into the syringe and insert the needle back into vial A, being careful not to push the plunger and expel the medication within the syringe into the vial. Withdraw the desired amount of medication from vial A into the syringe. After withdrawing the necessary amount, withdraw the needle and apply a new safety needle or needleless access device suitable for injection. If you're drawing up regular and NPH insulins, which one are you going to inject air first? NPH. So clear to cloudy, draw up regular insulin first. I will actually demonstrate this in lab, but not this week, the next week. We take two labs to go through MedAdmin. Most patients with diabetes who take insulin injections learn to administer their own injections. In the United States and Canada, healthcare providers usually prescribe insulin in concentrations of 100 units per milliliter of solution. This is called U100 insulin. Insulin is also commercially available in concentrations of 500 units per milliliter of solution. This is called U500 insulin. U500 insulin is 5 times as strong as U100 insulin, and it's used only in rare cases when patients are very resistant to insulin. To provide safe and effective care, you need to know the onset, peak, and duration of each of your patients' ordered insulin doses. You'll learn this in pharm. Only regular insulin can be given intravenously. The timing of insulin injections attempts to initiate that onset. Some insulins come in a stable premixed solution, like 70-30 insulin is 70% NPH and 30% regular, eliminating the need to mix the insulins on a syringe. Some patients are using insulin pens. The insulin pen provides multi-doses and allows the patient or nurse to dial in the dose, avoiding the need to use a syringe for insulin preparation. Use these principles when mixing insulins. A patient with diabetes sometimes requires more than one type of insulin. For example, by receiving short-acting, regular, and an intermediate-acting NPH insulin in a patient. It actually attains more sustained control of blood glucose levels over 24 hours. Insulin is ordered by a specific dose at select times. Correct insulin, also known as sliding scale insulin, provides a dose of insulin based on the patient's blood glucose level. The term correction insulin is preferred because it indicates that small doses of rapid or short-acting insulins are needed to correct a patient's elevated blood sugar. Reliance on correction insulin is unlikely to achieve long-term glucose control, though. Therefore, it should be ordered only on a temporary basis. Before drawing up insulin doses, gently roll the cloudy insulin preparations between the palms of the hands to resuspend the insulin. Do not shake insulin vials ever. Shaking causes bubbles to form, and then bubbles take up space in the syringe and alter the dose. If more than one type of insulin is required to manage the patient's diabetes, the nurse can mix 2 different types of insulin in one syringe if they are compatible. If regular and intermediate-acting insulin is ordered, prepare the regular insulin first to prevent the regular insulin from becoming contaminated with the intermediate insulin. Use these principles when mixing insulins. A patient with diabetes sometimes requires more than one type of insulin, for example, by receiving a short-acting, regular, and intermediate-acting NPH. A patient who is using both of these preparations attains more sustained control in blood glucose levels over that 24-hour period. Insulin is ordered by a specific dose at specified specific times. Correction insulin, also known as sliding scale insulin, provides a dose of insulin based on the patient's blood sugar level. The term correction insulin is preferred because it indicates that small doses of rapid or short-acting insulins are needed to correct a patient's elevated blood sugar. Reliance on correction insulin is unlikely to achieve long-term glucose control. Therefore, it should be ordered only on a temporary basis. Before drawing up insulin doses, gently roll all cloudy insulin preparations between the palms of the hands to resuspend the insulin. Do not shake insulin vials. Shaking causes bubbles to form. Bubbles take up space in the syringe and alter the dose. If more than one type of insulin is required to manage the patient's diabetes, the nurse can mix 2 different types of insulin in one syringe if they are compatible. If regular and intermediate insulin is ordered, prepare the regular insulin first and prevent the regular insulin from becoming contaminated with the intermediate acting insulin. Subcutaneous injections involve placing medications into the loose connective tissue under the dermis. Because subcutaneous tissue is not as richly supplied with blood as the muscles, medication absorption is somewhat slower than the IM injections. However, medications are absorbed completely if the patient's circulatory status is normal. The best subcutaneous injection sites include, make sure you learn these, the outer posterior aspect of the upper arms, the abdomen from below the costal margins to the iliac crest, and anterior aspects of the thighs. The site most frequently recommended for heparin injection, by the way, is the abdomen. Alternate subcutaneous sites for other medications, including the scapular areas of the lower back and the upper ventral or dorsal gluteal areas. The injection site you choose needs to be free of skin lesions, bony prominences, and large underlying muscles or nerves. The administration of low molecular weight heparin, like enoxaparin, requires special considerations. When injecting the medication, use the right or left side of the abdomen at least, this is important, at least 2 inches from the umbilicus, and pinch the injection site as you insert the needle. Administer this low molecular weight heparin in its prefilled syringe with the attached needle, and do not expel the air bubble in the syringe before giving the medication. There is some new evidence to support a slower injection rate of 30 seconds to reduce bruising and pain. Recommended site for insulin injections include the upper arm and the anterior and lateral parts of the thigh, buttocks, and abdomen. Rotating injections within the same body part, which is called intra-site rotation, provides more consistency in the absorption of the insulin. The injections are to be given at least 2.5 centimeters or 1 inch away from the previous site. Injection sites should not be used again for at least a month. The rate of insulin absorption varies based on the site. The abdomen has the quickest absorption, followed by the arms, thighs, and then the buttocks. A patient's body weight indicates the depth of the subcutaneous layer. Therefore, choose the needle length and angle of insertion on the basis of the patient's weight and estimation of the amount of subcutaneous tissue. Nurses typically use a 25 gauge 5/8 inch needle inserted at a 45-degree angle or a 1/2 inch needle inserted at a 90-degree angle to administer subcutaneous medications to a normal-sized adult patient. If the patient is obese, pinch the tissue and use a needle long enough to insert through fatty tissue at the base of the skin fold. Then patients often do not have sufficient tissue for subcutaneous injection. The upper abdomen is usually the best site in this case. To ensure that a subcutaneous medication reaches the subcutaneous tissue, follow this rule. If you can grasp 2 inches of tissue, insert the needle at a 90-degree angle. If you can grasp 1 inch of tissue, insert the needle at a 45-degree angle. The IM route provides faster medication absorption than the subcutaneous route because of the greater vascularity of muscle. However, IM injections are associated with many risks. Therefore, whenever administering a medication by the IM route, first verify that the injection is justified. The angle of administration is 90 degrees with larger needle width and length owing to muscle penetration. Use a longer and heavier gauge needle to pass through subcutaneous tissue and penetrate deep muscle tissue. A patient's BMI and the amount of adipose tissue influences needle size selection. Many needles available in healthcare settings are not long enough to reach the muscle, especially in patients who are obese and female. Because most agencies have needles that range in length from only 3/8 inch to 1.5 inches, investigate different medication routes, especially when IM injections are ordered for obese female patients. Muscle is less sensitive to irritating and viscous medications. A normal, well-developed adult patient tolerates 2 to 5 mL of medication to a larger muscle without severe muscle discomfort. However, large volumes of medication, 4 to 5 mL, are unlikely to be absorbed properly. Children, older adults, and thin patients tolerate only 2 mL of an IM injection. Do not give more than 1 mL to small children and older infants, and do not give more than 0.5 mL to smaller infants. Assess the muscle before giving an injection. Properly identify the site for the IM injection by palpating bony landmarks and be aware of the potential complications associated with each site. The site needs to be free of tenderness. Minimize discomfort during injection by helping a patient assume a position that helps to reduce muscle strain. Distraction helps decrease pain during the injection. When selecting an IM site, consider the following. Is the area free of infection or necrosis? Are there local areas of bruising or abrasions? What is the location of underlying bones, nerves, and major blood vessels? Also, what volume of medication is to be administered? Each site has different advantages and disadvantages. The ventral gluteal muscle involves the gluteus medius. It is situated deep and away from major nerve and blood vessels. This site is the preferred and safest site for all adults, children, and infants, especially for medications that have larger volumes and are more viscous and irritating. The ventral gluteal site is recommended for volumes greater than 2 mL. Research shows that injuries such as fibrosis, nerve damage, abscess, tissue necrosis, muscle contraction, gangrene, and pain are all associated with all the common IM sites, except for the ventrogluteal site. Locate the ventrogluteal muscle by positioning the patient in supine or lateral position. Flexing the knee and hip helps to relax this muscle. Place the palm of your hand over the greater trochanter of the patient's hip with the wrist perpendicular to the femur. Use the right hand for the left hip and the left hand for the right hip. Point the thumb toward the patient's groin and the index finger toward the anterior superior iliac spine. Extend the middle finger back along the iliac crest toward the buttock. The index finger, the middle finger, and the iliac crest form a V-shaped triangle. The injection site is the center of that triangle. The vastus lateralis is another injection site for adults and children. The muscle is thick and well developed. It's located on the anterior lateral aspect of the thigh and extends in an adult from a hand breadth above the knee to a hand breadth below the greater trochanter of the femur. Use the middle third of the muscle for injection. The width of the muscle usually extends from the midline of the hip, or of the thigh, to the midline of the outer side of the thigh. With young children, cachectic patients, it helps to grasp the body of the muscle during injection to be sure that the medication is deposited in the muscle tissue. To help relax the muscle, ask a patient to lie flat with the knee slightly flexed or in a sitting position. Although the deltoid site is easily acceptable, the muscle is not well developed in many adults. There's the potential for injury because the axillary, radial, brachial, and ulnar nerves and the brachial artery lie within the upper arm. Use this site for small medication volumes, 2 mL or less. Use the site only for small medication volumes when giving immunizations or when other sites are inaccessible because of dressings or even casts. Do not roll up a tight-fitting sleeve. Have the patient relax the arm at the side and flex the elbow. Palpate the lower edge of the acromion process, which forms the base of a triangle in line with the midpoint of the lateral aspect of the upper arm. The injection site is the center of the triangle, about 3 to 5 centimeters or 1 to 2 inches below the acromion process. You can also locate the site by placing 4 fingers across the deltoid muscle with the top finger along the acromion process. The injection site is then 3 finger widths below the acromion process. When administering IM injections, the Z-Track method is recommended to minimize local skin irritation by sealing the medication in muscle tissue. To use the Z-Track method, put a new needle on the syringe after preparing the medication so no solution remains in the outside needle shaft. Place the ulnar side of the non-dominant hand just below the site and pull overlying skin and subcutaneous tissue approximately 2 to 3 centimeters or 1 to 1.2 inches laterally or downward. Hold the skin in this position until you administer the injection. Grasp the barrel of the syringe with the thumb and index finger of the non-dominant hand and slowly inject the medication if there is no blood return or aspiration. The Centers of Disease Control and Prevention, the CDC, no longer recommends aspiration when administering immunizations to reduce discomfort. The needle remains inserted for 10 seconds to allow the medication to disperse evenly, rather than channeling back up the track of the needle. This leaves a zigzag path that seals the needle track where tissue planes slide across one another. The medication cannot escape from the muscle tissue. Intradermal injections typically are used for skin testing. Tuberculin screening and allergy tests would be an example of that. Because these medications are potent, they are injected into the dermis, where blood supply is reduced and medication absorption occurs slowly. Some patients have a severe anaphylactic reaction if medications enter the circulation too rapidly. You need to choose skin testing sites that allow you to easily assess for changes in color and tissue integrity. Thus, ID sites given to be lightly pigmented, free of lesions, and relatively hairless. The inner forearm and upper back are ideal locations. Use a tuberculin or small hypodermic needle for skin testing. The angle of insertion for an ID injection is 5 to 15 degrees, and the bevel of the needle is pointed up. As you inject the medication, a small blab resembling a mosquito bite appears on the surface of the skin. If a blab does not appear or if the site bleeds after needle withdrawal, there is a good chance that the medication entered subcutaneous tissue. In this case, test results will not be valid. Nurses administer medications intravenously by the following methods. As mixtures with enlarged volumes of IV fluids, by injection of a bolus or small volume of medication through an existing IV infusion line or intermittent venous access, or by piggyback infusion of a solution containing the prescribed medication and a small volume of IV fluid through an existing IV line. Medication administration is one reason for supplying IV fluids. IV fluid therapy is used primarily for fluid replacement in patients unable to take oral fluids and as a means of supplying electrolytes and nutrients. When using any method of IV administration, medication, observe patients closely for symptoms of adverse reactions. After a medication enters the bloodstream, it begins to act immediately, and there is no way to stop its reaction. Thus, take special care to avoid errors in the dose calculation and preparation. Carefully follow the 6 rites of safe medication administration. Double-check medication calculations with another nurse, and know the desired action and side effects of every medication you give. If the medication has an antidote, make sure that it is available during administration. When administering potent medication, assess vital signs before, during, and after infusion. Administering medications by the IV route has advantages. Nurses often use the route in emergencies when a fast-acting medication needs to be delivered quickly. The IV route is also best when it is necessary to give medication to establish constant therapeutic blood levels. Some medications are highly alkaline and irritating to muscles and subcutaneous tissue. These medications cause less discomfort when given intravenously. Because IV medications are immediately available to the bloodstream once they are administered, verify the rate of administration and a medication with a medication reference or a pharmacist before giving them to ensure that you give them safely over the appropriate amount of time. Patients experience severe adverse reactions if IV medications are administered too quickly. Medications are diluted in small volumes, 500 or 1,000 ml, of compatible IV fluids such as normal saline or lactated ringer solution. Vitamins and potassium chloride are 2 types of medications commonly added to IV fluids. There is a danger with continuous infusion. If the IV fluid is infused too rapidly, the patient is at risk for medication overdose and circulatory fluid overload. Current best practices include use of IV medications that come in standard concentrations and dosages, standardized procedures for ordering, preparing and administering IV medications, and ready to administer doses when possible. Nurses only mix medications into IV fluids in emergency situations. Administer the medication to the patient at the prescribed rate. Do not add medications to IV bags that are already hanging because there is no way to tell the exact concentration of the medication. Add medications only to IV bags. Remember. An IV bolus includes introducing a concentrated dose of a medication directly into the systemic circulation. Because a bolus requires only a small amount of fluid to deliver the medication, it is an advantage when the amount of fluid that the patient can take in is restricted. The IV bolus, or you may have heard it called push, is the most dangerous method for administering medication because there is absolutely no time to correct errors. In addition, a bolus may cause direct irritation to the lining of the blood vessel. Before administering bolus, confirm placement of the IV line. Very important. Never give a medication intravenously if the insertion site appears either swollen or edematous, or the IV fluid cannot flow at the proper rate. Accidental injection of a medication into tissues around a vein causes pain. It can cause sloughing of tissue, and it can cause abscesses depending on the composition of the medication. Determine the rate of administration of an IV bolus medication by the amount of medication that can be given each minute. Look at each medication to determine the recommended concentration and rate of administration. Remember to consider the purpose of which an IV medication is prescribed and also any potential adverse effects related to the rate or route of administration. Flush before and after with normal saline. The flush after medication is administered should be injected at the same rate as the medication was delivered. Something that I want you guys to note is that as students, you are never to give IV bolus medications. A piggyback is a small 25 to 250 ml bag or bottle connected to a short tubing that connects to the upper, what we call Y port of a primary infusion line, or to the intermittent venous access. The set is called a piggyback because the small bag or bottle is higher than the primary infusion bag or bottle. In the piggyback setup, the main line does not infuse when the piggyback medication is infusing. So for example, when we are hanging piggybacks, that tubing set comes with a tool that allows you to drop that primary infusion lower than the piggyback. If you don't do this, then that pump's not going to know any difference between the two bags, and it's going to deliver the heavier or the more fluid at the rate of the piggyback. So make sure that you're double checking on that and always lower that primary bag so that it doesn't go in before the piggyback at the piggyback rate. Nurses are legally required to document medications that are administered to patients. The nurse is mandated to document which of the following. Well, it is the one that's repeated twice on this slide. It is number 2 because it's very important.